At first, I would like to thank organizers for inviting me for this meeting. As you see, I will try to speak in English. It seems to me that my Polish English will be much better to translate into Polish than my real Polish translate into English. So there is some challenge for me, of course. I recognize that Alzheimer Europe is a leading organization in a worldwide campaign to improve life of people with dementia. In Poland, we still in the beginning of our way to help patients with dementia. We hope that the Polish European Union presidency now will be the occasion to increase pressure of our politicians to do something for our Polish patients, to improve their life, and Alzheimer Europe organization have a great experience in this topic to have some influence of politicians and will help us to make this pressure, our pressure, more effective. Alzheimer's disease and other dementias is a great challenge for all European societies, but in the last years a significant improvement in our knowledge about diagnosis and treatment was done. In a few slides, I will present the practical information about what we know according to diagnosis and treatment of Alzheimer's disease. At first, epidemiology. The increasing number of people with dementia is a fact. The WHO report estimates that dementia contributed 11.2% of years spent living with a disability in people over 60 years old, more than stroke, cardiovascular disease and cancer. In Polish general publicity, this relation is absolutely different. Many people in Poland believe that even the doctors that this stroke, cardiovascular disease are more important than dementia. In 2005, International Panel of Dementia Experts creates an evidence-based Delphi consensus on dementia prevalence worldwide and published the estimation that there were 24.3 million people with dementia in the world in 2001 and predicted that this would rise to 42.3 million in 2020 and to 81.1 million by 2040. But the quality of data on Alzheimer's disease prevalence varies between different regions, and we do not know if the differences in prevalence of ID in regions are real or not. To estimate the increasing cost of caring of people with dementia, we need a good epidemiological data in all countries. We can't extrapolate the data from one country to other country. Alzheimer's disease is a costly disease. European collaboration on dementia estimates that total direct and informal care cost of Alzheimer's disease and dementia to be euro 21,000 per patient across the 27 member states. 56% of them are informal costs. There is a large amount of data about potential risk factors for Alzheimer's disease, including age, genetics, and head injury. Meta-analysis and systematic review provide evidence that a cognitive reserve, this is the combination of benefit of education, occupation, and mental activities, as well as other risk factors like physical activity, midlife obesity, alcohol intake, and smoking, are the most important modifiable risk factor for Alzheimer's disease. There is insufficient overall evidence from epidemiological studies to support any association between some vitamin or B12 or folate or statins or antihypertensive drugs on cognitive function and incident dementia. So the conclusion is that a recent independent consensus expert report commissioned by U.S. Agency for Healthcare Research and Quality, published in Lancet Neurology in 2010, concluded that recommendation for Alzheimer's disease prevention cannot be made because the available evidence is not robust enough for safe advice to be given. We need further research into modifiable risk factors for Alzheimer's disease. Today's knowledge is not enough to prepare a real prevention. Next. Our understanding of pathogenesis of Alzheimer's disease significantly raised in the last decade. We are aware that the pathophysiological process in Alzheimer's disease began many years before the diagnosis of dementia. The possibility to recognize the pathological process in very early preclinical stage of disease provides the opportunity to therapeutic intervention to stop or even ameliorate the progress of disease. You can see from this slide that there at the beginning of the disease, just before clinical evidence, we have increasing number of pathologies. At first, there is pathology connected with beta amyloid. The second is pathology connected with tau protein. After that, the brain structure change, the atrophy increase. After that, we have a memory problem arising, and in the late phase, we have the dysfunction. So, with the prospect of development of disease-modifying drugs, early and accurate diagnosis is essential. But we still in the etap that the diagnosis of Alzheimer's disease and dementia is still based on clinical criteria. It's not an easy process. It's not an easy task. A lot of medical knowledge is needed to exclude many potentially treatable disorders that contribute to cognitive impairment. Improvement of diagnosis in primary care is a high priority because most patients of dementia present to family doctors, not to specialists. They are not prepared to early detection of cognitive impairment and for differential diagnosis. As a result, only 2/3 of people with dementia never receive a diagnosis. Practical approaches such as decision support software and practice-based workshops can improve detection rates and diagnosis and dementia. We should remember that. An expert consensus group led by Dubois has proposed in 2007 the new research criteria for Alzheimer's disease in an attempt to improve identification of people in the earliest stages of the disease. These criteria incorporate knowledge of biomarkers into clinical practice. Meta-analyses suggest that Alzheimer's disease can be differentiated from other dementias by detection of lower concentration of beta amyloid 142 and higher concentration of total or hyperphosphorylated tau in cerebrospinal fluid. Findings from a longitudinal study showed that this combination yielded a sensitivity of 95% and specificity of 83% for detection and early Alzheimer's disease in patients with mild cognitive impairment. That means that there is possibility to state that the patients with a very mild memory problem is in the danger to have a real Alzheimer's disease. Very useful is also a visualization of beta amyloid deposits in brain by positron emission tomography. You can see the slide showing how different is the imaging of the brain of Alzheimer's disease patient and the brain of the control healthy subject. This represents the deposits of beta amyloids, but these imaging are very promising, but it needs to be assessed in the larger multi-center studies. The next biomarkers is reduction of glucose metabolism in a special region of the brain. This imaging method has been approved in the US for diagnostic purposes and is sensitive and specific for detection of Alzheimer's disease in its early stage. Semi-quantitative structural MRI is also a useful marker identifying medial temporal lobe atrophy. On this slide, you can see the imaging from structural MRI, and this part of the brain, the medial temporal side, if you see, there is a very well visible changes in this region of the brain during the time. The differences between Alzheimer's disease patient and age-matched control individuals in this respect has a greater than 85% sensitivity and specificity. This year, in March, a new diagnostic criteria was published. They provoked many discussions between among specialists. Undoubtedly, these criteria represent a major step forwards. The authors do not recommend to investigate biomarkers in all cases in clinical practice. They think that before implementation of biomarkers into clinical practice, more validation studies are needed. And now the treatment. The slide summarizes the main licensed symptomatic treatment and most important pharmacological and immunotherapy for disease-modifying treatment. Cholinesterase inhibitors were thought to improve cognition and indirectly help function and behavior in patients with Alzheimer's disease. However, the outcome measures used in randomized clinical trials for the purpose of regulatory approval do not translate into day-to-day practice. Now, new measures such as goal attainment scaling are used, and the beneficial effect of inhibitor therapy has been reported. The next group of drugs, there is only one representative here, memantine, is also improve cognitive performance and function over 6-month periods compared with placebo. There is also seems to be addictive benefits of combining both drugs. And of course, some cognitive training might also be helpful as a symptomatic treatment. Antipsychotic treatment, especially by atypical antipsychotic drugs, these drugs are commonly used to treat agitation, aggression, and psychosis, but a serious adverse event is seen in many patients. Therefore, potential benefits and risks should be carefully balanced. Several disease-modifying treatments have been proposed, most of them involving beta amyloid, but some of them are at the end of clinical investigation, and we will have the results. But all the results published yet were negative, unfortunately. Alzheimer's disease cause not only cognitive decline and many behavioral disorders, but it creates a social isolation. There is some stigma attached to the disease. It decreases quality of life, not only the patient, but also a caregiver. It causes financial burden in the family. And it needs some special legal and ethical issues, because there are some differences from those of patients living with other long-term conditions. What patients and caregivers expect from us, from medical staff, from healthcare providers, from the society. From medical staff, patients and their caregivers need an early and accurate diagnosis, which should be aware about it. They need a practical information at the time of diagnosis, and in many cases they haven't it. They need an effective treatment, but not only the treatment of cognitive and behavioral disorder connected with this disease, but also the treatment of many comorbidities. Because the comorbidity rates, it's up to 50%. From the healthcare providers, they need a support. Generally, they need a support, especially in Poland. But they need a good care and the best practice models. There is a lot of models, and we don't know which one is the best. They need more integrated care services. Even in Poland, we have a lot of services, but they don't create unbroken care chain. This is the problem. And what they need is a long-term care, not only the action to do something to help for a few days, but a long-term care. There are some needs from society at the European level and the national level. There is a need to improving the quality of life, creating dementia-friendly society. There is a need to protection and rights. Some legal implication is connected with this. And they need volunteers to create a better day care. But I try to present what the patient and caregivers need. But all what are needed at the European level. In the public health, we need a continuing campaign to make in Poland and keep dementia a European public health priority in many other European countries. We need improving the legal protection of persons with dementia. There are some recommendations in this respect, but it seems to me that they should be implemented more largely. We need promoting the autonomy of people with dementia, and we need good collaboration between all involved in dementia care. According to the diagnosis, we still need a new criteria. We need to check it and to implement it. We need a new biomarkers. We need to check these biomarkers and implement to the clinical practice. We need also a prevention. As I said, there is no general rules scientifically oriented to be implemented by. There are some plans to have a more active and healthy aging. In the therapy, we need new drugs, and we need a standardization of the non-pharmacological management, because there is many non-pharmacological projects, but they are absolutely not possible to change from one institution to the other. In care and social support, we need a caregiver support, long-term care, and implementation of the new assistive technology. There is many new assistive technology, and we need the implementation of it. And we need a lot of education. The education focused on general public, the education for caregivers, to the general practitioners, to the specialists, and to the nurses. There are some specific approaches to address the challenges, and something in going, especially organizing by the European Union and the Alzheimer Europe. In the public health, it is joint action named ALCOVE. In the research, we have a joint programming in neurodegenerative diseases. Poland joined this program. In the pharmacological field, there is a pharmacoc, a big program, a big project, brings together scientists from 12 academic institutions and 11 global pharmaceutical companies. And we need a social prevention. At the Polish national level, we need at first our national plan. We haven't as yet, what we are in the creation. We need also some national recommendation in the field of not only medical, but also in psychosocial care. So, concluding, the Alzheimer disease, it's not only a challenge for medical staff and caregivers, but also for the researchers, pharmaceutical companies, politicians, journalists, and people around. Thank you very much.